So look, I'm coming into your office and I'm like, wait, you're going to give me 2 injections in my neck? Hold on a second. Where are these injections going and how do I know you're not going to mess me up? you know?
Well, I've done over 3,000. Everybody walked home, so we like that, right?
So those are good stats. I'm just going to say
Quite frankly, it's kind of unusual.
it's quite Franklin.
Quite got it. Quite Franklin.
So for the people that are listening, like give a definition of trauma, what types of trauma you can actually experience in life and how this applies.
Well, if I may, I'll go further back.
Please do.
So let's talk about the PTSD term, if you don't mind.
Please, yeah.
So if you look at history of that term, it's kind of interesting. The first term used for people who are traumatized and develop psychiatric conditions used to be called soldier's heart. That was during the Civil War. And the way they described it is people would get anxious, they would sweat, and they would kind of get blank faces, things like that. That was the description.
This was the description of what these soldiers were suffering post-war, not during times of combat, but after the war was over.
Or right after a battle.
Correct.
I mean, so, Civil War is extremely bloody, right? So half a regiment gets killed and people sitting around in shock, they don't know what to do with themselves.
Copied that, yeah.
World War One, they call it shell shock. World War II, they call it battle fatigue. So you probably heard this class, you probably have seen this picture, maybe video. A patient comes over to a guy who's sitting there totally distraught, he can't move, comes by, you're a coward, whacks him in the face and things like that. Do you remember that?
Yeah.
So the guy had basically severe PTSD and he was in shock. So it was not the most humane thing to do. So then in DSM-3, which is a diagnostic manual for psychiatrists, in 1980, they called PTSD, post-traumatic stress disorder.
Okay.
A buddy of mine is Dr. Frank Ogberg, who's a very famous psychiatrist. He came up with the term Stockholm Syndrome. You probably heard that term.
Yes.
He believes the term PTSD needs to be changed to PTSI, post-traumatic stress injury, meaning it's a biologic change. And if you look at it that way, there are a couple of things. We did a survey, which we're in the process of publishing. If we can change the name PTSD to PTSI, a lot of the stigma will go away. Because if you think about it, if you have a post-fracture disorder, who's going to get their leg fixed, right? But if you have an X-ray and say, hey, you have a broken leg, what are you doing? Let's fix it. No problem.
Yeah.
So you can look at PTSD or PTSI the same way. If you do a brain scan, advanced brain scans, you can actually see PTSD on a brain. So it's biologic. So if you look at PTSD or PTSI as a biologic phenomena, that's what I come in, right? So when there's any trauma, we wrote a paper in 2022 looking at treatment of PTSD, PTSI, 22 different types of trauma: military trauma, first responder, sexual abuse, and so on. And basically any kind of trauma. They all responded to stellate ganglion block. Okay. And the reason they did it, because if you think about it, if you're running from the tiger, right? Doesn't matter what color the tiger is, your body does a couple of things. Fight and flight system kicks up. And if it's too much, like it's overwhelming, then it gets stuck in that position. So physiologically, what happens in the brain is that when you have too much too much trauma, it activates something called NGF, nerve growth factor.
Yeah.
That goes from the brain to the neck to the stellate. It activates new nerve growth. So instead of 4 nerves, let's say there are 8, right? So they have a lot of it. As long as you have that many nerves, it produces more norepinephrine, which keeps you in this anxiety state. So if you take CSF or the fluid around the brain and analyze it for norepinephrine level, is likely to be twice as high as normal.
Because if you grow the extra nerve endings, I mean, would it go, for example, would it go from 4 to 8? Is it a doubling effect, or is it just an extra number of nerve endings? And then I'm assuming that those nerve endings themselves each produce the same amount of norepinephrine overloading the brain.
I'm just simplifying, right? I don't know exact number that happens. Human beings don't like their brains dissected.
Yeah.
And I just don't have enough neuroscience background. I'm just giving you a concept.
Yeah, gotcha.
Point is, we do know for a fact in the human model that norepinephrine goes up.
Yeah. So
No.
I guess the point of my question is that the number of nerve endings increase, and those nerve endings also produce norepinephrine. Like the body, if you have more nerve endings, the brain doesn't down regulate the amount of norepinephrine necessarily that's coming out of each nerve ending, because you end up with an excess in the brain.
Fair question. So first of all, the nerve endings I'm talking about is only the sympathetics, not
Correct.
the other ones.
Yes.
The fight and flight, right? So it's very specific. So I don't know about down regulation, but we do know there's more in the norepinephrine.
Okay.
So I know that. I know for a fact there is a study I can show you.
Yeah.
So the key point is, as long as that state persists, PTSD can last forever, right? We had a patient that we treated. He was a Vietnam veteran. We treated them 45 years later, and he still had a great response. Still has a great response. It's been 4 years since I treated him.
Yes.
And the reason that happens is because when I put local anesthetic on the ganglia, it reduces NGF, nerve growth factor we talked about, and it went from 8 back down to 4. So the number of nerves go back down. That's called pruning. So you reduce those extra nerves, norepinephrine goes down.
Okay, so it actually reduces all the newly grown nerve endings. It doesn't down regulate the output of each of those nerve endings.
If you look at rat model, so if you do NGF, nerve growth factor, if you inject inside the brain, there is sprout, so the extra nerves grow.
Correct.
Right. If you take away the NGF, there is pruning, so extra nerves go away. That's all I know.
When you talk about being able to see PTSD or PTSI, however we want to refer to it at this point, PTSI, in a brain scan, you're seeing that through the norepinephrine levels in the brain, or what's showing up that you can tell that a brain has suffered from PTSI?
There are two advanced nerve scans. One is fMR, functional MRI.
Yeah.
That shows, so the part of the brain that controls PTSD is considered amygdala. That's anxiety. You probably have heard of that.
Yeah.
It's part of the brain that controls anxiety and fear. So if antelope hears clicking in the woods, they start running because the amygdala lights up.
Okay.
So what happens is functional MRI picks up how much water is being utilized in which part of the brain. And then amygdala being overactive, you can actually see it. Or you can do PET scan, which is positron scan. They can show you the same thing.
And so it'll tell you that amygdala is overactive in the brain.
Correct. And there was one study done in Long Beach, California in 2015, where they took soldiers with severe PTSD. They did PET scan before, they did stellate, and they did PET scan after, and they showed deactivations of amygdala. So it calmed down to normal level.
So then if someone thinks that they are possibly a candidate for a stellate ganglion block procedure that you give, are they, say for example, I was like, okay, I'm interested in doing this. Would I want to go in for a brain scan to see if my amygdala is overactive? Would I want to test my norepinephrine levels to see if they're higher? Or how would I know that I'm a candidate for this versus you would say, well, you haven't really suffered any trauma, so you're not a candidate for this?
Well, first of all, let me go in reverse order.
Okay.
Number one, I don't think I'm in a position to evaluate the level of trauma.
Copy that.
Right. Depends how sensitive you are to trauma. I took care of one kid. He was walking across the hallway and trauma touched him in the shoulder, and he developed PTSD from that because he was very sensitive. So the current methodology, current gold standard assessment for PTSD or PTSI, PTSD technically, is PCL test, PTSD checklist, PCL-5 to be technical, or there is a more sophisticated one. But basically, people fill out the form, and if you're above something, certain number, you're a candidate. The scans are not really available clinically, and the problem with norepinephrine, you can't really just take a urine sample or blood sample. It has to be taking the fluid around the brain.
Oh,
and that's not a good technique.
Because here, I mean, just on a, I don't know, more philosophical level concerning this, like this concept, I was thinking, okay, because you use the idea in your book and the Invisible Machine about the caveman running from the tiger and constantly being in a state of stress, which is, I hunt. And so when I'm sitting in a deer blind and I watch a deer walk across the field, like every step that deer takes, like it can put its head down and start to like eat whatever, like some clover, for example, but then it'll snap its head up, and that deer never knows if that next step is its last step. So their fight or flight system is just active all the time. Much is the same
Right.
that if we're looking at life from an evolutionary perspective and cavemen were running around, then similarly, like you're running from the tiger and your norepinephrine, like that portion of the brain is constantly active. But now we live in a modern state where we sit in air conditioned houses and work office jobs where we're sitting on our butts half the time. A lot of people do, and we're not running from tigers anymore. So the question is, like, culturally speaking, or from a societal perspective, the amount of fight or flight that you need activated in modern society is not nearly as high as it would have been, for example, in the caveman caveman example in your book. But does that mean that it's necessarily unhealthy?
Fight and flight?
Well, like the fact that if you're in this fight or flight that you're in, the necessity of that is not as great as it was, I don't know, 3,000, 5,000 years ago.
Well, let me push back on that. I don't agree with that.
Yeah, okay.
So let's look at some numbers in our society, right? If you are a woman in the United States, your chance of being raped is 1 out of 3.
Wow.
And half of them will develop PTSD, right? So that's 1 out of 6 women, 1 out of 6 out of 150 million people. That's a lot of people. Also, if you're walking down the street, if somebody's trying to rob you, you probably want to be able to get going and run away.
But I would say, I mean, if the stats in the United States is that 1 out of 3 women will be raped, I don't believe that 1 out of 3 women are walking around the streets of the United States constantly like the deer eating the clover, going like, who's about to rape me next? Right? Like their fight or flight isn't activated all the time.
Well, I don't know. That's more of a societal question. It also depends on the neighborhood I think you're walking.
Yeah, well, of course. Yeah, okay. Agree with that for sure, for sure. But the kind of I guess the question I'm asking really is, if a woman in this example, if a woman was walking around like that and her fight or flight was engaged, then is that necessarily an unhealthy thing for her? Because
no, I think it's adaptive. We need fight and flight system to be able to survive, no question. And it depends. There is all type of trauma. There is first responders, let's say, when they go in the field, or firefighters when they go in the building, they need to be revved up, right? The whole idea between fight and flight is to make us survive. That's its function. So if you are a firefighter and you get into a burning building, you want to be firing in all cylinders, right?
Correct.
If you're a policeman, you need to be firing in all cylinders. You don't want to be on all the time, for sure.
Oh, that's right.
The side effect is such a sensitive system, it can get stuck in that position.
Copy that. Yeah.
And that's where you got problems.
Yeah, that's okay. I made a mistake in reading your book. It doesn't reduce the norepinephrine levels, or it doesn't deactivate the fight or flight response. It doesn't deactivate it when you need it. It only keeps it from being stuck in the on position.
Correct. And classic example of it is if you take SEALs who had PTSD and you treat them, instead of being like this and frenetic, now they focus like a laser, which is the best thing if you're out in the field.
Yeah. So asking this question for the listeners, when someone actually uses, when you apply this SGB to a patient, and it reduces the new nerves that have developed, which in turn reduces the amount of norepinephrine in the system. This helps reset it back to its quote like normal relaxed state.
Pre-trauma
state. So then you still have the ability to turn this on and off. So for example, if you've administered this to a soldier who is still active duty, they have the ability that when they go into war, the fight or flight can kick in when it needs to kick in.
That's true. Absolutely. We've treated a lot of active duty personnel, and we've treated a lot of police also in Chicago.
Okay.
And they are, if they can stay calm, they can get going when they need to. But the problem is if you're always revved up, right? If you're always looking around, you're not going to be able to see what you need to see. So in that sense, it's actually better.
so we're talking a lot about military, but I want to go back to this idea of trauma, because I'm not sure that a lot of people have this grasp on what trauma really is, because you start veering towards, and you actually mentioned this in your book, that people oftentimes think of first responders or military people, but I mean, it can be something like a rape, like a significant event. But what about someone, for example, who grows up in a poor environment and it creates this sort of brain setting where they're constantly in this fight or flight mode all the same? Would that be also classified as trauma? And if so, talk about how this is trauma, and, redefining what trauma really is for most people.
Yeah. So well, let's go back to definitions. I always like the definitions.
Yeah.
So if you look at definition of PTSD, in order to be technically classified as PTSD, you need to have experience outside normal human experience, such as military, rape, whatever, violence, something like that. I would say that's not an accurate description, because I've certainly treated a lot of people who had micro trauma. Let's say they're ignored by their parent for a long time. They have plenty of food, but they're always ignored, and there's always this tension. If a patient is sensitive, they can definitely develop PTSD. So the number of people who have PTSI symptoms, not in this, if forget definition for a second, if they have symptoms, is a very large number. At least 50% of the people can have that kind of thing. And as far as treating people from the hood, as you say, or from an underserved environment, I have done that, and I had a good response as well. So just being alive in that area could be highly traumatic, because there's always potential sense of doom or problems. Plus, you see your friends being killed and all of that stuff, right? Nothing personally may happen to that person, but just the mere fact you're immersed in that type of tough environment, there's not enough food, you're always scavenging for things. That's traumatic, of course, but doesn't have to be a huge event, is my point.
That's what I definitely learned when I was reading your book, because I grew up in an environment as a young kid where I moved quite a bit. From the time I was in kindergarten to the time I graduated high school, I was in 12 different school districts. And I had parts of my childhood that were very stable, where there's a certain piece of my childhood that I have very fond memories of, where I lived out in the country. And then other parts of my childhood where I was just bouncing from neighborhood to neighborhood and living in some, fairly rough neighborhoods, definitely low socioeconomic standards. And so for me, as I was reading the book and you were talking about trauma and some of the symptoms of trauma, I was looking at like these lists. I'm like, yeah, this applies to me. Like this applies to me. This applies to me at some level, because I guess my entire life I've lived out of as a good friend of mine refers to it, out of a place of scarcity. And living out of this place of scarcity has now created this mindset in me that is where I'm constantly working or looking for maybe the next biggest disaster or something that I have to overcome. It's kind of like life has taught me that when you're flying high, it's not going to last very long, because something will knock you down and you're going to have to climb back up that mountain again, so to speak. So when I was reading the book, as I was thinking about this and trauma, I mean, I wouldn't necessarily consider myself someone that has PTSD or PTSI that suffers from trauma or necessarily a traumatic event. But looking at trauma from that perspective, I'm not necessarily redefining it, but I'm redefining it socially, because most people wouldn't define it that way, as someone who has grown up in this environment that has created this mindset that falls into the same scenarios that someone who has suffered from a huge traumatic event, like going through a war or a rape or something of that nature.
So I didn't quite get the question, but let me give you an answer. I think maybe.
Yeah, it was more of a comment and thought on the book. Yeah.
And I appreciate it. Thank you. I hopefully you enjoyed it. So if you look, the way I look at it is, fight and flight system is very basic to us, right? And again, the simplification, there has to be one or multiple extreme events. I don't think it's necessary. What I'm interested in is symptoms. The question is, like when people ask me, am I candidate for the procedure, right? Let's say, basic question. Well, the answer is really simple. Here's some of the basic. Would you like to get rid of a couple of things? One, are you highly impulsive? Do you always feel there's doom? Do you have a lot of anxiety all the time? Do you have difficulty sleeping? Can you relax? If all of those things is a no, then you probably are a candidate, no matter where it came from. It doesn't really matter to me. I don't care what it came from.
Yeah, makes sense.
It doesn't matter, because the whole my whole career in medicine, which has been now a number of years, number of decades, is I hate the misery of suffering or anxiety and things like that. My mother killed herself when I was an intern, right? So I've seen that firsthand, what it's like. And I've seen, like, my father had PTSD. He gave that to me. He gave it to my mother. He gave it to my brother. So all of this, but the family with PTSD in it is really a hard family to grow up in. It's like always walking on eggshells. You're always waiting for the next blowout of some sort, right? Because people with PTSD usually kind of up and down because it's scary.
So, okay. So talk about this procedure, because this is a quick, like 15-minute procedure that you, when someone gets this shot administered. Talk about that and how it actually works.
Yeah. So basically the way it's done is we put an IV in. About 3/4 of the people we do like to go to sleep for it. When I had mine done, I was asleep. 1/4 doesn't want to go to sleep, which is fine. And then patients lies on the table. I use ultrasound to find out where all the vessels are, where everything is. And I put a needle under ultrasound guidance. And we put medicine in there. So I developed, first we start with SGB, stellate ganglion block. In the last 5 or 6 years, I've been doing DSR, dual sympathetic reset, we call it. There's 2 ganglion in the neck. There's one on the bottom, one on the top. So when we combine, it seems to work better. And I can tell you where it came from later if you like. But what actually happens physiologically, when you put local anesthetic on this ganglia, it seems to turn off the NGF, nerve growth factor. We talked about that originally.
Yes.
That NGF level is required to maintain the extra nerves, the sprouting. So once that drops, then the nerves die off. And that's why it works for a while.
Okay.
Or for a long time.
But it takes both shots in order to reduce the NGF?
It depends. So let me give you an example. So when I started doing it, I was just doing SGB, right? And then it worked about 75% of the time, which I thought was pretty good. We had a Marine sniper came in who I knew from before, back pain and stuff like that. Anyway, he comes in, I do this SGB, and it didn't do anything. And he was fully suicidal when I met him, which was very scary for his wife and I. Anyway, so I do the blocking. He's looking at 45 minutes later. It's like, I don't think so. Nothing's changed. We usually see significant results within 30 minutes. So I took him back and I did the C3 block. On the way out of the operating room, about 3 minutes later, he said, I feel great. And he was fine. And it turns out, and I went back and I looked at some books, turns out there are 2 places that nerves go from the neck to the brain, from here and from here. And they go to different parts of the brain. So sometimes SGB is enough, and sometimes it's not. That's why we combine the 2.
Okay, so the DSR, what was dual sympathetic reset?
Sympathetic reset. So it's dual for 2 levels, sympathetic and reset, rebooting it kind of.
So essentially the dual sympathetic is built off of the initial SGB injection, and then you're doing a second injection in the neck.
Correct, the same time.
Copy that.
I used to split it out, but I found it's easier to do it at once.
Okay. Now, in the book, you were talking about how sometimes people will come in and you'll do I think it's the right side of the neck, but then sometimes you end up having to do the other side of the neck. And why would that be?
So we always start the right side because the right side seems to be dominant for fight and flight or sympathetics.
Okay. So
what we find is that, let's say 80 to 85% of the time we'll respond to this procedure. But there are 2 amygdalas, right? Amygdala, we talked about fear, control in the brain. So there are 2 of them, right and left.
Okay.
So if the right one comes down, then what we find, if you go back and we do the left side, 50% of the non-responders from the right side will respond to the left side. So that's why we flip to the other side. And we see patient says, hey, I feel great, then we stop. If they don't, then we go to the other side.
And what is the efficacy on this? Like, what is the effectiveness rate? What percentage of people actually are experiencing, I'll use the word permanent, although, maybe permanent is, 5-10 years or whatever, but what is the percentage of people that are getting the positive benefits from this?
Well, I can actually give you some ideas what it looks like over time. So the longest outlier we have was the guy, he was a military man from 16 years ago we treated him. He's still doing well. He's got 2 blocks 16 years ago. So our typical success rate is 80 to 85% in people. When we look at the numbers, we start to just look at it. It looks like success rate is probably a couple of years out, up to 6 years, is in the 70s, which is, I think, pretty cool. It depends on a couple of things. It depends on genetics. It depends on what kind of aftercare people do. Like, do you do meditation? Do you do yoga? Have you changed your lifestyle? And number 3, did something bad happen again? So let's say somebody was, let's say a raped woman who's doing great and she gets attacked again. Obviously, it's going to come back. But stellate, the cool thing about this procedure, we're just putting a local anesthetic, the same drug that's used on pregnant women. It's not a steroid. It doesn't build up in your body. So for pain circles, sometimes we do like 10 or 20 of them. That's not that much of not a big deal. So potentially you can do multiple ones without much of a problem medically. Obviously, we try not to do that. But again, the length, how long it lasts, I'm not sure yet. But the results are pretty quick, which is great. So the compliance is high. If somebody comes in, they feel good when they leave, obviously that's great.
But when you talk about, say, a woman that was raped and then she gets attacked again, and then it can kind of reset her back to the overactive PTSI. So if she's experiencing PTSI, this is a growth of the nerve endings, which, going back to the original concept, is producing more norepinephrine. How long does it take to grow these new nerve endings? I mean, once you've experienced a traumatic event, it seems like PTSI sets in, or PTSD, however we want to refer to this, sets in, immediately, in essence. I mean, do these nerve endings grow that quickly?
I don't know the fine points of it, frankly. I've tried to investigate it. I'm sure it takes some time to grow it. But the problem is, if you have, here's how it works. So the amygdala is activated, right? Mm-hmm. It tells the fight or flight system time to run. And then whatever happens, and then the memory of the event keeps triggering the amygdala, keep activating the fight and flight system. So the nerves may not have grown yet, but the sympathetic system is still kicking in.
Yeah.
It's still working because the memory of the event is still fresh. As the memory comes down, a couple of things can happen. One, people feel great. Or it's still stuck in that position. That's the kind of people I get to see.
Okay. So then once the memory comes down, the nerve ending could still be growing, which keeps you in this perpetual state of overactivation.
Right. Correct. Okay. It's an interesting loop, isn't it? It's a loop system.
Okay. Talking about trauma, let's go a different direction, because I've been in the fight business my whole life. What about physical trauma? Right. For example, like people that suffer from concussion, CTE, things of that nature. I know these are different parts of the brain, but nonetheless, it is trauma, a different kind of trauma. And how does that fall into this discussion?
Yeah. So if I'd like to talk to you about special forces. So okay. I'm very proud to take care of a lot of special forces guys. So a lot of them have TBI and PTSD mixture. I was actually very fortunate to participate in Green Beret for the Day experience, which is really amazing.
Yeah.
So part of what we're doing was breaching, right? So you take down a wall or take down a door to get into. So we use very little breaching, but like they use real like C4 that blow off doors to enter whatever, hardened targets, things like that.
Yes.
So most of them get TBI more or less. And then they go through battle, so they have PTSD. So the mixture of PTSD and TBI in the special forces is called operator syndrome. Yep. It's a mixture of both. Because each one, so TBI makes PTSD worse, PTSD makes TBI worse. So what we do for special forces is we mix ketamine and stellate ganglion, or DSR. Ketamine grows, actually the nerves you want, not necessarily, it grows sympathetic nerves back, which is not good, but it grows other nerves back, like thinking nerves back, normal nerves, so to speak. So combination of the two seems to work well because they work synergistically together. So for CTE, that's what we do.
So in a brain where somebody is suffering from operator syndrome, where they have TBI and PTSD, when you inject the SGB, the stellate ganglion block, it will even though you're injecting ketamine that makes nerves grow, it makes I won't. I'll use the word all nerves, although I know it's not necessarily all. So all nerves in the brain.
Yeah, that's the thing. So it makes. I call it, in the simplest perspective, the good nerves and the bad nerves. So good nerve is the nerves that you think with. Prefrontal cortex gives you control, takes away depression, things like that. That's how ketamine works.
Yep.
But the bad nerves is the fight and flight nerves. So sometimes people get ketamine, they get pretty wild-eyed, occasionally.
Yeah.
We knock those things off with stellate. So we combine the two techniques. So all we want to do is we want to have the good nerves grow, reduce the bad nerves, which is fight and flight, sympathetic nerves, and improve the function of the hippocampus, like memory, because a lot of times CT and TBI, people have bad memory, right?
Yeah.
That combination seems to work well for that.
Yeah, just, I'm thinking about this because recently I'm not sure how familiar you are with our industry, but there was a guy by the name of Phil Baroni, who killed just really, really bad situation. And there were years ago where he was talking about how he needed help and with his brain. And so, I'm not sure if the current events were necessarily CT related or not, but it would have been interesting to see, had he gotten the proper help that he needed with his brain, if things would have resulted the way that it had, because he ended up killing his girlfriend. So
horrible.
Yeah, it's terrible. And and so when people see this, obviously that's the result. But at the end of the day, I can remember several years back where he was talking about his, having these thoughts and problems with his brain and reaching out for help. So, you just wonder, but in order to treat someone with CTE, you have to use the ketamine and the stellate ganglion block in combination with each other.
That's the best for us. That's the best result. Yes.
Okay.
There are other things you can add to it, but yes. So the bottom line is yes.
Okay. So look, I'm coming into your office and I'm like, wait, you're going to give me 2 injections in my neck? Hold on a second. Where are these injections going, and how do I know you're not going to mess me up?
Fair question.
Yeah.
Well, I've done over 3,000. Everybody walked home, so we like that, right?
Those are good stats, I'm just going to say.
Not bad, right? So, I've been doing this for 40 years. The first time I did stellate ganglion block was 1987. So I've been doing it for a bit.
Okay.
So first of all, where it's going exactly is here and here in the neck.
So what vertebrae are these?
C6 and C4.
C6 and C4, okay.
And then, so that's the first question. What is it going to? How do I know you're going to do a good job? That's your question.
Yeah.
I use ultrasound equipment, so I can see when I teach people how to do this. I teach 2 things. Number 1, where not to go. Number 2 is where to go, in that order, right? You see a carotid. You don't want to go to carotids. No.
Yeah.
Stay away from the carotid, right? So you see a bone here. You go over the bone, and that's where the target is. And you can actually see it with a needle on ultrasound, which is really cool.
Yeah.
And then when I inject the medicine, you can actually see it go in.
How precise does an injection like this have to be? Are we talking within nanometers of a spot, or?
Well, I'm not that good. No. It's within a couple of millimeters.
Yeah. Okay.
You have tolerance, because the other things, we put in a decent amount of volume, or the amount of medicine.
Yes.
So it's spread. So if you're in a neighborhood, it doesn't have to be like a stealth bomb. It has to be more like B-52, but you have to be in the right block.
Okay.
You can do carpet bombing, but you have to be pretty close to the block.
It's a perfect analogy, because when I was reading the book, initially, as I progressed through the book, initial questions that I had were well, what about this? And as I'm reading your book, a lot of these questions get answered for me. But I'm thinking I don't want somebody messing around with my neck. What if I end up coming out of there paralyzed, for example, right? And yeah, and so my question was not necessarily about your skill level or technique, but more about, well, because surely some people have had to gone through the procedure, and what are the negative repercussions of a quote unquote failed procedure per se?
Let me rephrase the question, if I may.
Yeah.
What are the side effects of a procedure, and what has actually occurred?
Yeah.
Excellent question. So, so there was a study done in Germany, country of Germany, in 1993. So before ultrasound, before X-ray guidance, right? Blind. We used to do it blind just by pressing. We're kind of getting an idea.
Yeah.
We're guessing. So they did 45,000 stellates. There's no fatalities. Nobody died. Nobody was paralyzed. They had 12 people had seizures. and then 9 people had pneumothorax, which is air in the lung. So the reason seizures happen, if you hit the blood vessel and inject inside the vessel, that could happen.
Okay.
And that's why with ultrasound, we can see the blood vessels so we can walk away from them, obviously. And we also go at C6, so we are away from the lung. So those are the main complications. They could be infections, bleeding, very rare, but it's possible. We're talking about 1 out of 100,000. We haven't had it happen, but it's possible, right?
Yeah.
I certainly haven't seen it, but if it does happen, there are medications. The reason we put an IV in is for safety. And then what's important is that we have supplies. There is medicine there, actually lipid, you can put in and stops the seizures, which is really cool.
Okay.
It sucks it out of the blood.
So this procedure, start to finish, takes how long?
From when I start and when I finish, 5 to 7 minutes.
And that's for both injections?
Yeah.
When somebody gets injected, when you say nerve block, the first thing that my mind goes to is when I had shoulder surgery and they wanted to put a nerve block. They asked me if I wanted the nerve block, which essentially made my arm go to sleep for a couple days. And the thought of having this just appendage that was dead hanging, I couldn't do it. So I was like, no thanks on the nerve block. I'm like, I would rather feel the pain in my arm, which for me was, a good choice. Like the pain wasn't so bad after my shoulder surgery, or maybe I just tolerated it well. I'm not really sure. I'd like to think I'm really tough, but I don't think that that's necessarily the case. But either way, I was a little nervous about getting a nerve block in my neck. And so that's where my head goes right away. When you have the SGB done, does it numb your arm? What are the feelings?
What you're describing is interscaling block. Actually, my teacher invented that in the 70s.
Okay.
So there's a brachial plexus, which is here. We are injecting more in, right? So the great thing about it, we can isolate fight and flight system. So the arm should not go numb.
Oh, gotcha.
It can happen occasionally. If the medicine escapes, I had a couple of patients, the arm got numb, not total flipper, but numb.
Yeah.
For like 3-4 hours. That happens occasionally if the kind of medicine escapes a little bit, but that's not common.
Okay.
Usually what people have is something called Horner syndrome. The eye will droop, the pupil will be small, and eyeball will be red. That lasts 5 to 8 hours. That usually means I hit the right spot. It's not a problem. And also the nose will be clogged up because the turbinate swells up. Mm-hmm. But you should not have a numb arm. No.
And then when you get this SGB done, you could leave there. I'm sure you feel, because you said that you're putting a decent amount of volume of medication in the neck. There's probably like a feeling of swelling in your neck, like pressure.
A little bit. Yeah. A little bit.
When that's over, how long does it take for this to kick in? The actual feeling of relief from your PTSD, PTSI.
I would say 50-60% of people have it within 30 minutes. Like, really? I've had people had smiling like a fool for a long time. I was like, they come in very, very tough looking or whatever, not happy, and feeling markedly removed because they feel this relief. The block kicks in about 5 to 10 minutes, maybe 15.
Okay. And
then a lot of times they feel a relief almost immediately. And if it doesn't happen, then we do the other side the next day.
And then that's just another 5 to 7 minute procedure. Same exact thing over again.
Same thing.
Okay, so if you experience like the stuffy nose, the droopy eye, the reddening, you said, what'd you call that?
Horner syndrome.
Horner syndrome. Is that on the side of the neck that you inject? So if you do the right side, I'm assuming your red eye gets red and stuffy. And
I hope so. If it's left, something's seriously wrong.
But then when you go to the left side, then
the safe side.
Yeah, then you're going to experience it the next day. Like if you have to get it done on the other side.
Right.
Okay. And so going back to the question I asked before, just because we've gotten deep into the woods on this thing now, if you have this procedure done and you have the relief from your PTSD symptoms, how long can you expect this to last?
It's variable. As we talked about, three things. Depends on your genetics, depends on what you've done afterwards. A lot of times people who do the best, if they can do meditation, yoga, some physical activity, and maybe some cognitive behavior therapy. What we love working with psychologists because a lot of times psychologists find that patients are more available. Yeah. So we're not talking about years, we're talking about a couple of months. So if they can do that, that seems to prolong the impact
Okay.
or the effect.
But if they didn't do that, I mean, assuming someone avoided any other, say, you're a female, you've been raped, and you avoided any other major traumatic event, and nothing like that has happened to you again, but you haven't taken the time to self-improvement, whatever, working on the.
You can still work. I mean, I've seen it work for years. Really? And we've had I saw a patient like that recently, and she came in 5 years later and she said, I didn't do anything. I was doing great, but it's gradually is coming back. So my husband said, I think it's time to come back. So one procedure for her lasted 5 years.
And then after 5 years, she can come back in and have it done again.
Yeah. She called me up, said, I think she was from Kansas. She flew back in. It's like, okay, all right, I'm ready, doc.
Wow. And so just like that, in minutes, you can make someone that's suffering from any kind of traumatic, stressful event or whatever in their life, you can reset their system on them.
I think so. I mean, it seems to work. Like I said, last publication, 2022, we looked at 22 different types of trauma, and it worked on all of them. So military trauma, all types, bullying.
Oh wow! So how many different how many people have received this procedure at this point in time?
Military has probably done 5,000 to 10,000. I'm not sure exact number.
Yeah.
I've done about 3,000. It's an organization where I'm a medical director, Stellate Center. We've probably done another 4,000, something like that.
Yeah.
So it's a decent number. We're getting into decent numbers.
Yeah. And you're experiencing. And when was the first the DSR, the first time you did a dual sympathetic reset? What year was the first time you did that?
About 6 years ago. That was a sniper. About 6 years out.
Okay, and obviously, I'm assuming they're still doing well.
Well, I followed him 5 years, so I knew 5 years out he was doing fine. Considering he was doing terrible when I saw him, I think that was a win.
Okay, yeah.
Only one procedure.
Okay, and is this procedure that, for example, like health insurance would cover?
Not yet.
Not yet.
Still working on it.
Still working on it. Yeah. Just ballpark, how expensive is a procedure like this then?
I think it's like we charge about $2.5K, something like that.
Okay.
Yeah, so it's like we need to have psychologists talk to them. We do this, whatever. But yeah, it's about, I think, is it $2.5K, something like that.
And then if somebody's doing the procedure and they have it done on the left side, is it? I'm just curious. Is it another $2.5K to have it done on the right side too the following day? If it didn't work?
I don't remember. I think there is some kind of package with that. I don't recall how that's done. Gotcha. I try to focus on the science of it.
Yeah. I mean, it just kind of it puts things in perspective that I'm when I was reading the book, like as I started reading, I had so many questions. I'm coming out of the gate and I'm like, well, hold on a second, and this and that. And then as I continue reading the book, a lot of my questions were answered. And then it's one of it really is. I mean, there are a lot of examples in there of different military people that have come in and people that have suffered trauma. It goes into the history of the SGB, the initial shot, and then you doing this DSR, putting in the second shot, and it's one of those scenarios where I'm reading this and I'm like, in the medical field, I just say this: if something is too good to be true. In life in general, something's too good to be true, then it's just not.
100%.
Yeah. But particularly in the medical field, it's always that way. And as I'm reading this, I'm like, man, this sounds so, it's so simple. It's call it a 15-minute procedure in and out. And if it doesn't work, you come back the next day, get it on the other side, and a 15-minute procedure in and out. And you're having over 70, over 80% success rate with your patients for a fairly extended period of time. That I'll ask this: on when you have these patients that come in, say someone after a 5-year period and the shot has worn off, the nerve endings are beginning to grow back, the norepinephrine levels are raising in the brain again. When a person has this done a second time, similar success rates as far as results go?
I don't have an absolute answer. A lot of times, theoretically, it should be better.
Better.
If you look at, because if you look at literature like CRPS, which is a burning of the hand, that's originally a stellate you use for that. Every time you do one, it seems to last longer for pain. Here, but I don't have enough data, so I can't give you a direct answer.
So,
but if it's every 5 years you do a procedure, that's not bad.
Yeah. So this procedure when it used for other applications seems to have a even more prolonged effect, like the second or third time that it would be done. Is what you're saying?
Correct. For pain.
For pain.
Also, somebody, let's say, there is a cohort of people that sometimes they do a procedure and only lasts like a week, right? Let's say good response, but very short.
Yeah.
So in that case, we do something called pulse frequency. It's an electrical way of doing the same thing, only longer. So we switched to that approach.
It's called what again? Pulse what?
Pulse therapy, pulse radiofrequency modulation.
How does that work?
I can't explain to you. Yeah, let me tell you about that. So again, I'm a pain guy, right? So
yeah,
that procedure's been out 30 years also. So let's say somebody has a nerve that's injured after groin surgery for, let's say, hernia, right? So they come in, I do the block, I numb up the nerve, last couple of days. We come back and then we send electricity we put a needle, it's an insulated needle, put it on a nerve, and it activates certain genes inside the nerve.
Mm-hmm.
And that can last 3 months to 3 years for nerve pain. The same thing here. That's why we use that technique.
Okay.
To make it long.
So if I were to have come in and got had the DSR done with the 2 shots and it only lasted a week, then you would go in with the radio frequency, with the electro,
right?
And then that would prolong its effects.
Correct, and that could be months or years.
Either way, no matter which way you go, how you cut the pie on this one, it's a fairly non-invasive procedure that's quick in and out, and on the downside, you get a little droopy eye and maybe have to do it again the second day. But by the time you have a second droopy eye, your first droopy eye is already gone.
Why, it should be, yes.
Yes.
And then it's called percutaneous procedures. It's invasive, but it's minimally invasive. It's not like, we are going through the skin. So you can say it's not invasive.
Well,
but everything else you said is perfect.
Yeah. I guess I use the word, I use the phrase non-invasive for me. If I don't have to be put under, that's pretty non-invasive. I was poked in the eye in a fight one time, and I ended up having to have this procedure done to my eye where they had to cut scar tissue off my actual cornea. And yeah, you always make that face. And I make that face too. Like, I've had plenty of stitches around my eye, and I don't like seeing needles come towards my eye. Like, it's just, when you start having needles coming at your eye, but they had to, when I had this procedure done, they had to, because what ended up happening is that there's so much of the cornea was chunked out when I got poked in the eye. And this was during my Dan Henderson fight, that as it grew back, there was a scar tissue over top of it. Now, this is what I would consider a non-invasive procedure, because I didn't have to be put under for this, but they had to cut the scar tissue off my eyeball. They had to numb the eye socket, the entire eye socket with several shots, which was weird. Then my eye went numb.
I used to do that injection. So compared to that, this is not invasive.
Yeah, exactly. So, but I'm not even done yet. I'm not even done describing the procedure. Then they had they had to prop my eye open. And then, and then they're coming in with a scalpel and they're cutting it off. And then they had a soldering gun where they had to cauterize my eye to keep it from bleeding. And to me, as I'm awake watching this thing while they're doing it on my eyeball, I'm literally, I can smell the smoke of burnt flesh coming off my eyeball. That's non-invasive to me. So it's more of a personal definition of what non-invasive is. So this coming in, getting a couple shots and walking out is that's non-invasive to me. Technically, I guess by medical definition, it is invasive.
Well, I try to be a clinician, right? But I agree with that. That just sounds awful.
It actually, other than getting the shots in the eye socket, it wasn't, the pain on it wasn't that bad. It was, those things hurt, but once the eye was numbed up, I actually walked out of the doctor's office and drove home.
Well, you're in the business you're in, you're very tough.
So yeah, well, yeah, I would like to think so. It makes me sound tough, but yeah. So if I can drive home, then it's a fairly non-invasive procedure, I guess. So can you drive home from this procedure?
We prefer not. First of all, if people do it on the local,
yeah.
They can.
Yeah.
But here's the interesting thing. There was a study done years ago where they did EEG, electrical monitoring on the brain, and they found after the block, people get sleepy just from the block.
Oh.
So people can drive home, but it depends what shape they're in. If they're too sleepy, we just keep them around for a bit. But yeah, they can drive home.
Yeah. Okay. Yeah. That's non-invasive by my definition. So, well, okay. So let's do some plugs here. If people are interested in this, your book it's not been released yet, right? Like I technically got an early copy of the Invisible Machine. Did I not?
You did.
Exactly.
Yeah, the book is coming out April 11th.
Okay.
It's going to be available on Amazon. Hopefully it does well. And if people are interested in having a stellate ganglion block done, or DSR, which is my favorite, of course. So I'm a medical director for Stella Center. It's stellacenter.com. And we have offices in about 35 states currently.
Mm-hmm.
4 offices in Australia and one in Israel.
Okay.
So we're getting to be an international company.
And then they can go to your personal website as well for information on you.
Absolutely. It's drdrugenelipov.com.
Yeah. Okay.
That has a lot of medical information and sciencey stuff, as my friends call it. And I practice in Chicago. So if a number of people come to Chicago so I can treat it. If they want to have it done close to their home, they can do that too.
Yeah. I will, I'll be up in Chicago in a couple of weeks. So I don't know if actually I don't have this built into my schedule, but if I'm there, I might swing in and at least talk to Daphne about it a bit more, because she had set this up and everything. This procedure, whether I feel like I need it or not, either way, I just know that in my business, particularly with the amount of head trauma and the damage that's done to the brain, from that perspective, this could really help. But then, like I said, as I was reading the book, there was just scenarios where I never really thought of myself as someone that suffered from trauma per se. And trust me, I mean, I'm a product of the 80s, right? Like the Gen Xers are like the rub some dirt on it and get back in the game generation. So in my generation, we're like, what? You need to just toughen up, like I am General Patton. Like I am the guy that's smacking somebody like, come on, just, quit being a sissy. But nonetheless, when I was reading the book, I was like, wow. And so I do find myself perhaps kind of in that fight or flight mindset more often than I realized until I read the book. I was like, wow, this does, a lot of the symptoms in here do apply to me. So it's like, if you, I guess my message is to somebody like, if you're listening to this, and even if you don't think that you've suffered some sort of traumatic event, like this is definitely, the book is definitely a worthwhile read for you, for something to consider, because when you're assessing life, and for me, like I said, it's always like I'm always like safeguarding myself from the next possible world-ending crisis or something, and so that's like, at least not necessarily world-ending, but I mean that metaphorically speaking, like in my own life, like so, like the next thing that's just going to knock me down in life, and I'm constantly like, okay, where is it coming from? Because good things can't last forever. I see those
fibers growing.
Yeah, right.
I see the growing fibers.
I don't think you see them growing. I think they've already grown. That's the thing. And so that was kind of like my realization. I was reading this book. I was like, wow. And so I think I have to get over that macho side of my brain and convince myself that maybe something like this is really something that could be beneficial for me.
One thing you may want to think about is, one of the ways, what people ask me is like, how do you decide, first of all, if you need it done, and how do you decide if you need to come back, right?
Yeah.
That's a very common question. My usual answer is, if you have a significant other, they'll tell you.
Yeah.
When you start, because they see a difference, right? You feel good, you're playing with the kids, everything is good. And now a year later, 2 years later, 5 years later, 10 years later, you start to isolate. Now it becoming difficult again. They go, it's time to go back.
Yeah.
Go and get treated again.
Yeah.
Because it's obvious, a spouse can see they're emotionally connected, right? They can see what's going on, or your parents or whoever, loved ones.
Yeah. So I don't know. I just, for anybody out there that knows someone that's, suffering from trauma or withdrawn or something like that, I would definitely check out Dr. Lipov's website and his information. And when the book comes out, give it a read. It's a smooth, quick read anyway. And it was definitely very informative.
I didn't write it. I had a professional writer help me, believe me. I can't write it.
So, I mean, the information has to come from you at some point in time and passed on to your ghostwriter. So it was definitely informative, to say the least. And so I appreciate the read, and it'll be exciting when other people can get their hands on it.
Thank you. Well, I hope I get to meet you in Chicago. Not necessarily with a needle in hand, maybe a drink.
Yeah. Either way, maybe one day needle in hand, but if not, maybe a drink in hand the other way.
Whatever you think, sir. Not at the same time.
Yeah, I appreciate you coming on. Thanks for your time today.
Thank you, sir. Have a good
Awesome.
day.
Yeah, you too.
Quite Franklin is providing this podcast as a public service, but it is neither a legal interpretation nor legal advice, nor a statement of Quite Franklin policy. Reference to any specific product or entity does not constitute an endorsement or recommendation of that product or entity by Rich Franklin or Quite Franklin. The views expressed by guests on the podcast are their own, and their appearance on the program does not imply an endorsement of them or any entity they represent. Views and opinions expressed by Quite Franklin employees or representatives are the views and opinions of the persons expressing them, and do not necessarily reflect the views or opinions of Quite Franklin or any of its officials or principals. Nothing heard on this podcast at any time is medical advice or is intended as medical advice. The listener must always consult his or her personal physician or other qualified medical professional regarding any questions of a medical nature. If you have any questions about this disclaimer, please contact our general counsel.